These are all connected. These are connected here. I mean, right down to the thyroid, to the larynx. Breathing, speaking, singing, they're all related. Connected to the larynx, the sternum, the clavicle. The height going doesn't drop, the larynx doesn't drop, the sternum, the clavicles turn inward. We got asthma. We get forward head posture. Solid glasses can't lift the posterior tongue. Normal palatal development cannot happen. It cannot happen. You can't get the posterior tongue up. You can never get normal palatal development. It's a big picture of myofunctional therapy, Mark. And also, you can't breathe through your nose because the bell's so high and the sinuses are so small. And you don't breathe through your nose, you got to take Viagra for your whole life. No, just kidding. You can fix it. We can fix it. We know how to fix it. That's what I'm telling you. Cool, look at this. Everything's connected together. I mean, look at this. They all, right down to the clavicle, the sternum, the twin, I mean, they're all connected. So if this one doesn't work right, what makes you think this one's going to work right? Doesn't work. That's the problem. That's why we have to go through the myofunctional training. We have to get the muscles to do what they're supposed to do. We put the face through oral facial boot camp. That's what you got to do. I'm telling you, your chronic pain patients, look at them. Look at them. You're talking about 85, 90% of them have these problems. They do. So all the stuff that you're doing, not diminishing it, but I'm just telling you, you want to make them better, let's look for the etiology. Let's look for what's causing the problem. Again, tongue, hyoid, larynx, they're all connected up there to that process up there. Oh yeah, by the way, what is this hooked onto? Any ideas up here? What's up here? What bone is up there? Which one? Temporal bone. Oh yeah, temporal bone. Oh yeah, what is the temporal bone the other half of? Right. TMJ, right?
When you put an appliance in somebody's mouth, when you treat them for sleep, when you treat them for TMD, what are we doing? Well, you're reducing inflammation. You're getting the patient to stop hurting themselves. You're getting the patient to breathe and sleep better, and often we talk about that. Often I have a patient who's eating something who, I'm not even going to talk about allergies per se, it's a lot more subtle than that. They eat foods that cause inflammation. It causes inflammation often in the nose. If it causes inflammation in the nose, they become mouth breathers. They become mouth breathers, the video. So, you need to have a conversation. Even people who sit in front of you with a BMI of 18, okay, they could be very, very inflamed. Understand your endpoint. Where are you going? What is it you want to achieve? Now, patients must be informed of the possible permanent changes in the TMJ that would preclude them from returning to their original occlusion. Okay, this is referring to whether you're going to recapture a disc or not. That's a half-a-day discussion in itself. You need to prepare the patient that, you know, it seems to be acceptable if you put a sleep appliance in somebody's mouth and over the next few months it's a natural byproduct that the bite changes a little bit. Well, you better believe that a TMD appliance, you may get some of the same things happening. Okay.
30, 4 hours a night during any of those first 90 days. However, if we look in other areas of the world, what is compliance in Europe? France is 3 hours a night, 7 nights a week, 21 hours. In Germany, 4 hours. Italy's 3 hours, Spain's 5 hours. So what is compliance? Which definition is more correct? If we look at the research, here's an article that says that 46 to 83% of the people on CPAP do not comply. They do not adhere to treatment. And if you look at other research, they'll even show you that 4 hours a night, that's not good enough. We know from the research here at the Defense and Civil Institute of Environmental Medicine outside of Toronto that a soldier needs at least 3 hours a night to kill, to be an effective soldier and kill the enemy and not kill themselves or their cohorts. Right? So to be able to fire a gun and to be a good soldier and operate equipment, you need at least 3 hours a night of consolidated sleep. Here they're saying, well, 4 hours a night or more on CPAP. But if you look at other research, they say, well, what's your dependent variable? What is your result that's going to say that that level is the level that you need to achieve to have a benefit? If your cutoff is using the Epworth Sleepiness Scale, then you need it to be higher. If you're going to use cognitive functioning, you need to be in the neighborhood of about 6 or 7 hours. So 4 hours is really low. So CPAP is the #1 treatment for sleep apnea here in North America, but in countries in Europe, they've got 55% of the market being oral appliance and 45% being CPAP. The compliance is low, intolerance is common. We know all these side effects, claustrophobia, swallowing air. One of my favorites is where the bed partner gets a stream of air blowing on them in the middle of the night, like that, because the patient rolls over and the mask gets loose. Dry mouth. So one of the things when you're talking to sleep labs is you can say, hey, we'll make you look better, give us all of your CPAP intolerant patients. So CPAP, is it a gold standard?
But we can see similar etiologies like tight frenums, bottle feeding perhaps will, especially if combined with overuse of pacifier, train the tongue to go forward, and that can lead to a low oral rest posture. These are learned behaviors. So the brain thinks that's where the tongue should rest. The brain starts to think it should breathe orally rather than nasally. We have our modern world forces leading to sippy cups, pacifier, put a pacifier in the kid's quiet. Our diet, there's a lot of market pressures to push baby food, to push soft foods, fast foods. You don't get the same genetic expression when you're chewing. This is a great book, The Evolution of the Human Head, where the author, a Harvard biologist and anthropologist, postulates that the human head is exceeding the speed of evolution due to all of these causal factors. Myofunctional therapy originated in its current state. The term was actually coined in 1934 by the first president of the American Association of Orthodontics, their predecessor agency, who wrote 50 papers working with Alfred Rogers on myofunctional therapy. But really as a therapy.
She had incisors that were lingually inclined, that were built out to give an illusion of a smile line, that were this thick. So when they're this thick, that poses yet a different problem. That will pose and cause a constricted envelope of function problem, which we will talk about, and I will explain what that means later. So you wonder why some of these class 2 Div 2 patients have TM joint problems. You're going to find out later. So what we did with Annette was we did a combination of ortho and restorative, and we did a full mouth rehab. I guess you could say I did it twice, orthodontically and then prosthetically. So it's in some of the porcelain work, everybody, the thing is, I'm going to tell you this, many of the cases I'm going to show you, I don't like. They're too white. The minute that somebody gets out of pain, guess what they want? They want to look good. And you know what? They look good, they want to look like American Standard white. They want that toilet bowl white. But that doesn't look great. Okay, I've got a couple of cases that I'll show you that look better, but how can you argue with what the patient's perception is? So you give them what they want. And then finally, sleep disordered breathing. 30% of sleep patients have a TMD problem. How do you know which 30? Okay, so you do a biopack, and then you come out with an occlusion like this. When you're just looking at teeth, can you tell anything about their joint problem or their sleep problem? You might get some hints, but there's nothing there that tells you that. So in this case, in Keith's case here, we had to give him a day orthotic as well as a sleep appliance. Now, if somebody here says to me, I only use appliance X all the time,
I say run from that patient, run from that doctor. Because they are making every patient fit that one appliance. You have to identify what the patient's needs are and then design an appliance that fits that patient's need. If this patient had severely crowded teeth, would a tap appliance be a good choice for that patient? Binding those teeth together? Probably not. Would a Narval appliance be better? Probably, but when I did this case, Narval wasn't in Canada yet. Okay, but then what would my other option be? You do a Somnodent with a Gelb bar, and you redesign the Somnodent to fit what you need. A lot of times people, our dental colleagues, don't realize that you can make modifications to appliances. All you have to do is tell Lionel. You say, Lionel, I got this problem. Lionel's Lionel and Lorna from Orthodent. And you say, I got this problem. How can we jig this appliance to make it work? Well, you know, we cut out the coverage and we make a Gelb bar, and all of a sudden you got this and that and whatever. Or you got now they have an LVI design, which is a very neat little bikini design that fits for your patient's needs. But if you only have one instrument to provide your patients with a treatment, I think you're doing the patient a disservice. You're making them fit, and then you wonder why it doesn't work. Well, maybe that appliance wasn't the right appliance for that patient.
Now, the instructions you tell to the patients need to be consistent. For every patient need to be the same. Specific for every picture. One is smiling, one is nothing. Okay. Give the instruction as short as you can. If you can say, oh, can you stand there, put your arms up on the side and look kind of straightforward, that's too many steps. Then they are not natural anymore. Okay. Script your instructions. You have to write it down, what kind to tell. Okay. Now, even if you got a mugshot, anybody recognize this kid?
Yeah, he's too rich.
Yes. Bill Gates. He got caught. So if you ever had a mugshot, those guys have their own protocol. Why? Okay, the board is up there, hang up here, the camera sits here on the tripod, everything's already set. So all the pictures are very similar. Okay. So this is how I set up my protocol. Okay. This is the first picture. Okay. Looks straightforward. That's all the instructions. Okay. We're not kind of telling, okay, put your lips together or anything like that. Okay. Face should be centered. Hair should not obstruct the ear. Glasses off, and one with glasses on. Okay. Top of shoulder need to be visible. Camera at the right height. What does it mean? You got a younger person, you are really tall, you're not just going to tilt your camera. You have to lower down yourself. Okay. So that's an important part. And the same thing, opposite. You got a very tall person, you cannot do it properly. Maybe the person has to sit down and you can take the camera, the picture at their level.
Now, why do people, and a lot of people have seen, some people, you see, they have lots of symptoms, and dentists went through his 4 types of patients. How come some people have no symptoms? How come some people have worn down dentition? How come some people have worn down joints? How come some people have recessions? Weak link theory, one of my mentor, Noshir Mehta, at Tufts. The damage to the masticular system from intense perfunctional can be assessed by the weak link theory. There's going to be something that's going to break down. Orificial structure, teeth, periodontal tissue. The more intense and more prolonged the forces, the more the tendency to damage. The weak link theory explains a little bit why we see so many different presentations of patients. Because in this room, we all have a different weak link. Mine is not the same as Richard. Richard's is not the same as Dennis. Why? Because we're all different. We have differences. Different capacity to adapt to different stresses. Now, how do we evaluate occlusion? Occlusal indicator, waxes, articulating paper, foils. That's what I've learned in dental school. That's what I've used in dental school. I still use that today. And we do depend on these to locate and define the occlusal contacts that we come upon. And we depend on the accuracy of these indicators in our treatment to regain occlusal harmony, but also for diagnosis. And we depend on these precise registrations. We depend on that. It's necessary. Now, marking paper will leave a mark. It's going to give us a specific site as to where the teeth articulate together when they touch. That's what marking paper does. And it does it well, sometimes. Now, one thing that we have to bear in mind is paper cannot, and I repeat, cannot indicate the amount of forces applied to a tooth. Okay? And I've learned this in school, and we assume, and one should never assume, and I'll let you know, decide why you should not ever assume. Vivid contact, the location is assumed a large contact, more force is being applied. Well, guess what? Physics is proving us wrong on this one.
So what if they're diagnosed? What happens? They're put on Haldol, Effexor, Paxil, Zoloft. Fantastic. What does that do to them? It makes them grind. Uh-oh. That's going to start hurting their muscles. And even better, what happens when they're grinding? They go back to their doctor, and then they put them on Buspar, Propanolol, Neurontin, Botox. Well, now we have neural problems or neural changes going on. We have a vasodilator going on, or we have something that's going to just basically kill the nerve, and it's going to grow back. Not great. What are the other problems that go on with the antidepressants? Is they all have a fluoride molecule with that. And why would I care about that? I'm a dentist. Fluoride's godsend, except that it's not. If you read the literature, it's a toxin. In our dental literature in the 30s, it was diagnosed as or noticed as a toxin. But here's why. Never mind the liver cancers and the bone cancers. I'm just going to talk about how it affects our TMJ and sleep. One, fluoride has an affinity towards the pineal gland. The fluoride also has a strong affinity with aluminum. As a matter of fact, all of our bauxite production, a huge amount of electricity is used from there to be able to remove fluoride from there. So we're dealing with a waste product is what it is. And actually they're putting in hydrofluorosilicic acid and not the stannous fluoride that we've all been trained and studied about. So what they're doing with that is then putting this hydrofluorosilicic acid into our water. We have no idea how much we're drinking because it's dose dependent on how much water we have. So we might be having higher doses. The fluoride goes into our body, has an affinity towards the pineal gland, and the aluminum in our body now has an affinity towards the fluoride, goes to that area, calcifies the pineal gland. So what? What does the pineal gland do? Well, it protects us against neurodegeneration. That might be important to us. It also has an effect on melatonin. That's where it's produced. And if melatonin production isn't happening, we're not going to be sleeping properly. That could be a problem. That can create a whole other load of symptoms. And so, who's the treatment group that we're treating nowadays? 16 to 26-year-olds? What are they doing in their life? They're in their laser-like focus to try and get ahead in life. They're going to high school trying to get into university. They're in university trying to get into their professional programs. They're out of their professional programs trying to make their mark in the world. What are they doing nowadays?